Alright guys, so as you can see, today we are going to discuss another topic from respiratory system, and it's acute respiratory failure. So as you can see, I have written already the definition of acute respiratory failure. As you can see, that failure of respiratory system to maintain adequate gas exchange, resulting in insufficient oxygenation of blood and insufficient removal of carbon dioxide. So when do we say that the patient or the person has developed acute respiratory failure, right? So basically you have to understand that what is the function of respiratory system, right? To provide oxygenation to the blood and to remove carbon dioxide from the blood. So if any of these functions is compromised, if any of these functions is compromised, then we say that the patient is in respiratory failure. And if it develops within days, we say it's acute respiratory failure. All right, so now in acute respiratory failure we are further going to discuss hypoxemia and ARDS, because these two are the conditions, hypoxemia and acute respiratory distress syndrome, ARDS. These two are the conditions which ultimately lead to acute respiratory failure if they're not immediately or promptly managed. All right, so first of all, let's start with hypoxemia. What is hypoxemia? As you can see, hypoxemia is decreased partial pressure of oxygen. If I say in simpler terms, it decreased partial pressure of oxygen within our blood, right? Arterial blood, decreased partial pressure of oxygen. Now, why this decreased partial pressure of oxygen is happening? Why the partial pressure of oxygen is being decreased? All right, there can be many reasons or many etiologies for this decreased partial pressure of oxygen. Number one, and the most important one, is VQ mismatch. VQ mismatch. Now VQ mismatch means ventilation perfusion mismatch. V means ventilation and Q means perfusion. Ventilation perfusion mismatch. So what exactly does it mean by ventilation perfusion mismatch? Now it happens when the ratio of ventilation, that is the air flow towards the alveoli, to perfusion, that is the blood flow to the alveoli, is off balance. All right, so what does it mean, off balance? Ideally ventilation and perfusion should be matching each other for efficient gas exchange, right? So as you know, these are the airways, and these are the alveoli, and this is our alveolar capillaries, and this is alveolar capillary interface, and this is the area where the gaseous exchange takes place. Carbon dioxide goes out and oxygen comes in, right? Now VQ mismatch happens if there is too much blood supply, right? Too much blood supply as compared to the ventilation, means not enough air is coming in, but the blood is more than that equivalent amount of air that was supposed to come. The blood is coming more, but the air that was supposed to come here into the alveoli, that is not coming in that amount. That is when ventilation perfusion mismatch happens. Means perfusion is good, blood perfusion is good, but ventilation is not good. Or in other case, ventilation is good but perfusion is not good. So any of the case where you can see ventilation perfusion mismatch, that results in decreased partial pressure of oxygen. Now when do we see increased perfusion and decreased ventilation, and when do we see increased ventilation and decreased perfusion? All right, so increased perfusion and decreased ventilation. We have many different diseases like interstitial lung diseases, okay? Interstitial lung diseases, alveolar diseases, right? And parenchymal diseases of the lungs. In these states, all of these disease, the ventilation is compromised because these are damaging our alveolar portion, or these are damaging our bronchioles, right? So when our alveoli or bronchioles are damaged, it means ventilation cannot be maintained properly. Ventilation cannot be maintained. Not enough oxygen is reaching up to the alveoli. Not enough air is reaching up to the alveoli because of these disease. But perfusion is normal. Perfusion is the whatever the blood was supposed to come for oxygenation, that is coming. Perfusion is normal. Only the problem is in ventilation, and this problem can be seen in these diseases: interstitial lung diseases, alveolar diseases, and parenchymal disease. Now let's come to the second scenario, in which ventilation is absolutely normal. There is no problem within the lungs itself. Lungs are completely healthy. Ventilation is absolutely normal. The problem is in the perfusion. It means that there is some disorder in which the blood which was supposed to go to the alveoli for gaseous exchange, that is not going in that amount. So perfusion is compromised. And there are two scenarios in which perfusions can be compromised. Number one, pulmonary embolism. You all know that if the embolus from the distant part of our body, for example, as in deep venous thrombosis, sometimes it gets embolized, right, and it goes into the pulmonary circulation and it blocks the pulmonary artery. When it blocks the pulmonary artery, the amount of blood which was supposed to go into the alveoli for oxygenation, that is not going there now. That's not going there now. So that is when perfusion is decreased, we say, right, in case of pulmonary embolism. Secondly, in case of decreased cardiac output. So when there is decreased cardiac output, right, ultimately we know that blood is not going normally to other parts of the body because the heart function is compromised. Heart is in a state of failure. So that is why there is decreased cardiac output, because heart in a state of failure. When heart is in a state of failure, it is not able to maintain the perfusion to the lungs. When it's not able to maintain the perfusion to the lungs, all right, that is when we say that the perfusion has been compromised, and that is leading to VQ mismatch. VQ mismatch means ventilation perfusion mismatch. So now, up till now, we have discussed two possibilities of VQ mismatch. Number one, in which ventilation is compromised, okay, but the perfusion is normal. And the second scenario, in which ventilation is normal, right, but the perfusion is compromised, right? So this is how VQ mismatch can lead to decreased partial pressure of oxygen. Decreased partial pressure of oxygen within the arterial blood, ultimately leading to hypoxia or hypoxemia. So this was one mechanism of how hypoxemia develops in our body. Another etiology for hypoxemia to develop in our body is right to left shunt. Now what does it mean by right to left shunt? All right, so this is our heart and these are four chambers, right? Suppose if there is an opening here in the atria, congenital anomaly, these are atrial septal defects and ventricular septal defects. These are congenital anomalies, right? If there is atrial septal defect, and normally we know that pressure on the left side, this is left heart and this is right heart, pressure on the left side is much higher than the pressure on the right side. So normally what should happen is that blood from the left atria should go into the right atria, because pressure in the left atria is higher than the pressure in the right atria. That's what normally happens if there is a shunt. Of course, in normal conditions there is no shunt, there is no mixing of the blood. But suppose if there is shunting, then because pressure in the left atria is more than the pressure in the right atria, then blood goes from the left atrium to right atrium. But under certain circumstances, opposite can happen. The blood goes from the right side to the left side. So there are conditions in which there is you all know that from left side what comes out, which supplies blood to whole part of the body, aorta, right? Aorta. And from right side what comes out, which supply the deoxygenated blood to the lungs for it to get oxygenated. What is that? that is pulmonary artery. So if there is pulmonary artery vasoconstriction, right, pulmonary artery vasoconstriction, then what happens is that the blood from the right side cannot go there because of pulmonary artery constriction. It cannot go to the lungs, right, because pulmonary artery is in a constricted state. Then the pressure in the right side starts to build up, because the blood which was supposed to go into the lungs to the pulmonary artery, that is not going there now. As a result of that, pressure in the right side starts to build up. If the pressure in the right side starts to build up, then in the presence of this defect, automatically the shunt shifts from right to left, right? So initially I told you that normal way for shunt is to go from left to right in the presence of this defect. So in the presence of this defect, normally the shunt should go from left to right, but here in this scenario the shunt will move from right to left. All right, as a result of which the blood which was present in the right side of the heart and which was supposed to go to the pulmonary artery for oxygenation purposes, that is not going now there. It is instead going into the left heart. If it is going into the left heart, it means in the left heart there is oxygenated blood present already. So it means if the blood from right side is mixing with the blood in the left side, it means there is mixing of oxygenated and deoxygenated blood. If there is mixing of oxygenated and deoxygenated blood, it means that from aorta, what blood will go out to the body, will be delivered to the body? Of course, mixed blood, oxygenated, deoxygenated, mixed blood, right? So the level of oxygenation in our systemic circulation will go down, because now the blood which is going there, it is not purely oxygenated, it has deoxygenated blood mixed in it also. Because it has deoxygenated blood mixed in it also, the level of oxygenation will drop down in our systemic circulation, and that will lead to decreased partial pressure of oxygen. All right, so first one, the reason was VQ mismatch. Second reason is right to left shunt, which is leading to decreased partial pressure of oxygen, and that is called hypoxemia. Okay, so up till now we have discovered two etiologies for hypoxemia. Number one, ventilation perfusion mismatch. Number two, right to left shunt. All right, so guys, moving our discussion forward with the causes and etiologies of hypoxemia, let's move on to another cause of hypoxemia, that is hypoventilation, right? Hypoventilation simply means inadequate ventilation, right? And hypoventilation can be because of many different things. For example, number one is muscle weakness, especially respiratory muscle weakness. Now, under which scenarios do we see respiratory muscle weakness? Okay, so first of all, you all know there's a neuromuscular disease, okay, like myasthenia gravis, right? Myasthenia gravis, which leads to the weakening of the muscles in our body, especially skeletal muscles. It affects skeletal muscles, and also affects the muscles of the rib cage, the muscles of ventilation, the muscles that help us to exhale and inhale, active ventilation, right? So these neuromuscular diseases like myasthenia gravis lead to muscle weakness, respiratory muscle weakness. If respiratory muscles are weak, they will not be able to maintain enough ventilation, right? And if they are not able to maintain enough ventilation, that's ultimately leading to hypoxemia. The other reason for respiratory muscle weakness is chronic diseases like COPD and asthma, right? So these are chronic lung diseases in which the patient usually experiences shortness of breath, right? Almost all the time the patient is dyspneic, right? When the patient is dyspneic, it means he has hard time breathing. He puts an extra amount of effort to maintain ventilation, to maintain breathing, right? When he puts an extra amount of effort, it means that he's using his respiratory muscles more efficiently to get breathe, right? If he's using his respiratory muscles more, it means that is lead to muscle fatigue. That is leading to muscle fatigue. If muscles are fatigued, respiratory muscles are fatigued, they will not be able to maintain enough ventilation, and when they are not able to maintain enough ventilation, that is going to lead to hypoxemia, right? So this is one way in which hypoventilation through muscular weakness leads to hypoxemia, right? Another reason for hypoventilation is CNS depression, central nervous system depression, right? Especially those people who are on opioids and they like uh, overdosages, if they undergo overdosages of opioids, right, or they are addicts and they use opioids as an addiction, that may lead to central nervous system depression. If that portion or that area of the central nervous system is depressed, which is responsible for our breathing, for our respiration, that is ultimately leading to hypoventilation, of course, right? So opioids overdose, right, anesthesia, anesthetics, right, anesthesia especially in old patients. So while performing any surgical procedure on old patients, we have to be very very careful, because anesthesia can produce strong central nervous system depression in old individuals, right? So opioids, anesthesia, sedatives, right, analgesics, so these are certain medications which can produce central nervous system depression, right? So central nervous system depression ultimately leads to hypoventilation, and that leads to hypoxemia. So this is how we have covered the third etiology of hypoxemia, that is hypoventilation. First was VQ mismatch, okay, VQ mismatch. Second was shunt, right to left shunt, and third is hypoventilation. All right, so guys, let's move on to the other etiology of hypoxemia, and that is low inspired oxygen, right? And it's usually mostly related with high altitudes, right? So suppose an individual with already some underlying lung condition, for example pneumonia or COPD, chronic bronchitis, go to some mountains. We know that at high altitudes the partial pressure of oxygen is very low in the air as compared to the normal altitudes. So because of that, the inspired oxygen in that altitude area is already low, right? And because he is suffering from an underlying lung condition, that just simply aggravates his condition, because he is already having some lung problem, and on top of that he is not getting enough oxygen because of that altitude. So that's going to produce hypoxemia in that patient. The last etiology is diffusion impairment. What does it mean by diffusion impairment, right? It means that air cannot diffuse across the alveolar capillaries, okay? Air cannot diffuse across alveolar capillaries, and it can be seen in conditions like fibrosis, edema. So this is alveolus, okay, and this is capillary, right? Suppose if you make this area fibrotic, right, if you make this area fibrotic due to some fibrotic condition of the lung, do you think air will be able to pass through properly? No, of course not. Or if you make this area edematous, right, edema, pulmonary edema, if you make this area edematous, which is mostly seen in heart failure, pulmonary edema develops in heart failure. So if you make this area edematous, of if you make the alveoli fibrotic, do you think proper gaseous exchange happen? Of course that's not going to happen. That is called diffusion impairment, and diffusion impairment ultimately leads to what? Hypoxemia. So these were the etiologies for hypoxemia. There are 5 etiologies up till now that we have discovered. Number 1 was VQ mismatch. Second was right to left shunt. Third was hypoventilation. Fourth is low inspired oxygen content. And fifth one and the last one is diffusion impairment. Now let's move on to see how we can evaluate these patients who present with hypoxemia, right? So of course, when they have low oxygenation levels in their body, first of all we have to evaluate these patients through history and physical examination. So when these patients will come to us, they will have decreased oxygen saturation, right? Decreased oxygen saturation. Not only that, they will be tachypnic. They will have tachypnea, and because of tachypnea they will have dyspnea. So tachypnea simply means rapid shallow breathing, and dyspnea is a shortness of breath. So most of you guys are quite confused in these terms, tachypnea and dyspnea. You can use these terms in an overlapping condition, because tachypnea, when you breathe rapidly and do shallow breathing, you ultimately develop shortness of breath. So these are the terms that you can use in an overlapping fashion, not always but sometimes. So in that case, if the patient develops tachypnea, he will of course develop dyspnea, shortness of breath, right? And he will have pleuritic chest pain. Pleuritic chest pain, of course, because he has been like coughing, wheezing, especially if he has conditions like asthma, bronchitis, COPD, that will produce pleuritic chest pain, right? And the patient will have altered mental status. You can imagine, because there is low oxygen pressure in the arterial blood. Because of that, the brain is not getting enough oxygen. If the brain is not getting enough oxygen, that is going to lead to altered mental status. All right, so these are some upon physical examination, these are the things that you will observe in these patients. Now let's come to the most important topic, most important section of this whole topic, that is diagnosis. That is very, very important, and it usually get tested on examination as well. Now how do we diagnose hypoxemia? So you might be thinking, how to diagnose hypoxemia? Isn't it weird? We already know that the patient has decreased saturation of oxygen, decreased partial pressure, tachypnea, so he's hypoxemic. All right, we know that, but we have to determine the underlying cause of that hypoxemia. What is the underlying cause of that hypoxemia? We have discussed 5 etiologies up till now. What etiology is causing hypoxemia exactly? That is when we start diagnose patient, that's what comes in our mind, that what exactly is the etiology for hypoxemia, and that is going to be very, very interesting, right? So patient presents to you with hypoxemia. Listen to it very, very carefully. This is very, very important. The patient comes to you with hypoxemia means he has decreased partial pressure of oxygen, right? When he has decreased partial pressure of oxygen, you already know that, right? What do you have to do now? You have to check his AA gradient, capital A minus small a gradient. You have to check his AA gradient. Now what does it mean by capital A? Capital A mean partial pressure of oxygen in the alveoli. Okay, partial pressure of oxygen in the alveoli, and small a means partial pressure of oxygen in the arterial blood. Okay, arterial blood. Now, how do you measure the partial pressure of oxygen in the arterial blood? Of course, by obtaining ABG, arterial blood gas, right? By obtaining ABG, you measure what is the partial pressure of oxygen in the arterial blood. But the question is, how do you measure partial pressure of oxygen in the alveoli? That is very, very important. There is a very complex formula. It is not that complex, but to some people it seems very complex. So there is a formula in which you can measure the partial pressure of oxygen in the alveoli. So what's that formula? Okay, so PaO2, which is partial pressure of oxygen in the alveoli, is equal to FiO2, okay, multiplied by atmospheric pressure, okay, minus PH2O, bracket closed, minus PCO2 divided by R. So that formula is very, very important. Okay, now let me tell you, what does this mean? What does this FiO2 mean? FiO2 is fractional inspired oxygen. Fractional inspired oxygen, okay, and its normal value is 21% at room air. Okay, at normal altitude, at normal air, at room air, its value is 21%. Okay, and what does it mean by PATM? Of course, it is atmospheric pressure, which is 760 millimeter of mercury. Okay, 760 millimeter of mercury at sea level. All right, and what is PH2O? It is partial pressure of water vapors. Partial pressure of water vapors. Its value is 47 millimeter of mercury at 37 degrees centigrade. All right, and what is PCO2? It's partial pressure of carbon dioxide that you obtained via ABG, arterial blood gas. Okay, so you obtain PaCO2, which is partial pressure of carbon dioxide via ABG, and R is a quotient. R is a constant number, and its value is 0.8. All right, so now you get all the values that you have to put in this equation. When you get all the values, you put in this equation. Now let's go to the other page and draw it all the way again, right? Patient was hypoxemic, okay, hypoxemic. You measure his AA gradient, right? AA gradient means you subtracted partial pressure of oxygen in the alveoli from partial pressure of oxygen in the arterial blood. When you measure this AA gradient, if that AA gradient turns out to be normal, if that AA gradient turns out to be normal, then what you have to do, you have to see that if in this individual the partial pressure of carbon dioxide is increased or not. The partial pressure of carbon dioxide is increased or not. If it is increased, if the partial pressure of carbon dioxide in this individual is increased, it means that this hypoxemia is because of hypoventilation, right? Hypoventilation. So now you get to the etiology, right? You check the patient is hypoxemic, right? Then you measure AA gradient. If AA gradient turns out to be normal, then you look for partial pressure of carbon dioxide. If the partial pressure of carbon dioxide is increased, yes, if it is increased, then the likely etiology for hypoxemia is hypoventilation. But if it is not increased, if the partial pressure of carbon dioxide is not increased, then the likely etiology for this hypoxemia is decreased fractional inspired oxygen that is related to high altitude. All right, so that's one thing. Now when this AA gradient turns out to be increased, suppose, then what do we do? In that case we check if the partial pressure in that case we check that if partial pressure of oxygen which is in the arteries, the partial pressure of oxygen which is in the arterial blood, if that is correctable with supplemental oxygen, right? So we give supplemental oxygen to this patient, right? And if after giving supplemental oxygen to this patient, his partial pressure of oxygen in the arterial blood is corrected, if it is corrected, then we have, okay, so let's go to the other page. So if the partial pressure of oxygen is corrected in this individual, by after giving supplemental oxygen, it means that this hypoxemia was most likely because of the ventilation perfusion mismatch. But if in this individual whose AA gradient was increased and after giving supplemental oxygen, his partial pressure of oxygen is not corrected. If it is not corrected, then it means that the likely etiology for hypoxemia was shunt, right to left shunt, right? So this is how we can diagnose the etiology of hypoxemia. We already knew that the patient is hypoxemic when he presented in the emergency, but to diagnose what is the etiology of that hypoxemia, this AA gradient, this table is very, very important. So you must all understand how we calculate AA gradient, and then how after calculating AA gradient we reach up to the etiology of hypoxemia, right? So that's how we diagnose. Other diagnostic criteria, we can perform chest x-ray, because when we do chest x-ray, we can see if there is an infiltrative process like pneumonia or no, if the patient is suffering from pneumonia or no, because pneumonia is a disease which lead to VQ mismatch, and that can lead to, of course, ventilation perfusion mismatch and hypoxemia. You can see if the patient has pleural effusion, okay, that can lead to hypoxemia. You can see if the patient has atelectasis, okay, by doing chest x-ray, and you can see if the patient is having pneumothorax, okay, pneumothorax. All are these conditions that lead to hypoxemia, right? The ultimate diagnostic criteria which gives you the cause of hypoxemia is this AA gradient. Otherwise you can also do chest x-ray to find out the underlying etiology, right? So that's how we diagnose hypoxemia. Now, how do we manage hypoxemia, right? First of all, in management, okay, we treat the underlying condition. That's very important, okay? You have to treat the underlying condition, otherwise your hypoxemia will not be corrected. Second of all, we administer supplemental oxygen right away. Supplemental oxygen right away. As soon as the patient presents in an emergency with hypoxemia, we you put the patient on supplemental oxygen right away, right? So if the patient is hypercapnic, means his partial pressure of carbon dioxide is so much increased, right, his partial pressure of carbon dioxide is so much increased, means he is hypercapnic, then we have to put the patient on mechanical ventilation, right? While mechanical ventilation, we need to maintain PEEP, right? PEEP is positive and expiratory pressure. Positive and expiratory pressure. In the next video, where I will discuss the other reason for acute respiratory failure, which is acute respiratory distress syndrome, I will tell you what exactly is PEEP, what exactly is positive and expiratory pressure. In this video, we covered hypoxemia, which is one of the causes of acute respiratory failure. We saw how hypoxemia develops, how there are many etiologies for hypoxemia, and we also covered how we diagnose the etiological basis of hypoxemia. See you in the next video with acute respiratory distress syndrome.